Hi, good morning, everyone. I am Mary. Good morning, everyone. I'm Mary Beth Kwapniski. I'm the program coordinator at SCAN. I'm happy to have you join us this morning for Meet the Physicians with Monmouth Medical Center. Before I introduce our panel and our moderator for this morning, I wanted to remind you that all questions can be entered into the chat feature at the bottom of your screen. And please always remember to hit the enter button so it is sent to us directly. So again, it is my pleasure to introduce our panel for this morning and our moderator, Dr. Granet. So I'll ask everyone to join me on camera for a moment. Good morning, everyone. So Dr. Granet is our moderator for this morning. Dr. Granet is the Chief Medical Officer at Monmouth Medical Center. So thank you for moderating, and I will give you the pleasure of introducing our distinguished panelists for this morning.
Mary Beth, thank you, and good morning, everybody. It's a pleasure to be able to moderate this panel. I'm looking forward to the interaction with the group. Please be aware that if you have questions, to send them out. We want it to be as interactive as possible for everyone. Without further ado, let me make some introductions. First of all, my name is Dr. Granet. I was trained as an internist. I have been a chair of medicine at Monmouth Medical Center. I'm currently the Chief Medical Officer here at the hospital, and I'll be the moderator for today's event. So let me introduce our panelists. First panelist I'm going to introduce is Dr. Dmitry Olyenikiov. Dr. Olyenikiov received his medical degree from the Albert Einstein College of Medicine and did his surgical residency at the University of Utah in Salt Lake City. After completing his residency, Dr. Olyenikiov served as a senior fellow at the University of Washington School of Medicine and served full-time faculty at the University of Nebraska up until he became the surgical chair here at Monmouth Medical Center. Dr. Olyenikiov has been an active investigator and a contributor to medical research. He has published over 200 peer-reviewed articles and 250 abstract presentations. The Society of American Gastrointestinal and Endoscopic Surgeons has recognized him for his achievements with an award in excellence in leadership, and he serves on its board of directors and is currently the chair of the robotics committee. Currently, he is our chair of surgery at Monmouth Medical Center. And if I went on, we would take up the entire hour with his CV. So it's a pleasure to welcome Dr. Olyenikiov.
Thank you so much, Dr. Granet. It's just a pleasure to be participating today.
Thank you, Dmitry. The next panelist I'll be introducing is Dr. David Anwar. Dr. Anwar received his Bachelor of Arts and Honors in Biology from Rutgers University, and then went on to get his DO, Doctor of Osteopathy, at NICOM in Westbury in New York. He did his postgraduate training at Penn State for internal medicine, his cardiology fellowship at DeBoer Hospital, and his interventional cardiology fellowship at DeBoer Hospital as well. Dr. Anwar is an interventionalist cardiologist. He is board certified, and this is going to be fun to read all of these to you: internal medicine, echocardiography, nuclear medicine, general cardiology, interventional cardiology, cardiac CT, and vascular ultrasound. Dr. Anwar works in the Monmouth Heart Specialist Group in Eatontown, New Jersey. Welcome, Dr. Anwar.
Thank you, Dr. Granet. Pleasure to be with you today.
Our third panelist is Dr. Melissa Gonzalez. Dr. Gonzalez received her undergraduate degree from Rutgers as well, and went on to study medicine at the Ross University School of Medicine. Her postgraduate training is at Mountainside Family Medicine, where she is a board certified physician. Her interests are outpatient primary care and women's health, and she really has a fascinating background. And one of the things that Dr. Gonzalez has done is she's been a volunteer in the Operation Enduring Freedom Volunteer at the U.S. Army Post in Italy for many years. So she has a very interesting background. We're very excited to have her on the panel. Dr. Gonzalez's office is through Barnabas Health Medical Group in Neptune, New Jersey. Welcome, Dr. Gonzalez.
Thank you so much for having me, everyone. Hopefully we'll have great conversations today and you guys have a lot of takeaway points.
Excellent. So let's get started. We're going to start with Dr. Dmitry Olyenikiov. Dr. Olyenikiov, here's a question that I think is germane to our time frame now. With holidays approaching, all of us need to be aware of our gastrointestinal health. So a common question I will get as an internist, and I'm sure you as a surgeon will get is, what do I do if I have heartburn after a meal?
Thank you for that question, Dr. Granet. And it is a very common problem today in our society. There are a number of things contributing to increasing rates of heartburn. We're all probably a couple of pounds heavier than we should be. Many of us are eating late at night because we have busy schedules. And all that contributes to basically the stomach contents leaking and causing a little bit of burning in our esophagus. They leak through a valve called the lower esophageal sphincter, or just a fancy term for a valve that keeps the stomach from leaking back up into our swallowing pipe. And so what I tell patients is that, number one, it's not uncommon and certainly not something that they need to be worried about if occasionally they have heartburn, especially if they have a big meal, especially if that meal is late at night. Think Thanksgiving's meal. And especially if they tend to have, along with that meal, items that quote unquote relax that valve, things like chocolate for dessert or red wine, or some other common items in the Thanksgiving meal as a whole. Typically, what you have to do is you have to try to fill the stomach less and eat earlier. So before you go to bed, the stomach has a chance to empty. That usually takes a couple of hours. I tell most of my patients that if you're going to bed at 10, you better be eating your last meal at 6. And that really is sort of the everyday advice. I can also tell you that if you're having heartburn all day, every day, whether you've had a big meal or not, then that's something to seek advice about. There are plenty of over-the-counter remedies, but I don't recommend using those for more than just a couple of days, because if this doesn't go away, that could mean something more serious. And that would require a trip to your primary care physicians to discuss why you're having heartburn all the time. Causes of heartburn that are common and may mean something needs to be done are, for instance, a hiatal hernia, which is where the stomach is really kind of going through your diaphragm and causing the valve to not function properly. A bad leak, so to speak, can cause changes in the esophageal lining that can cause problems for you, which may require additional endoscopy or other procedures to be done if not caught early. So I do say, listen to your body, eat healthy, try to lose some of those extra pounds, but definitely see a physician if the problem is not just limited to the Thanksgiving meal.
Dmitry, just a follow-up question from me. When you say the word valve, you're not talking about an actual valve, are you?
Well, that's a great question, Ken. So when we swallow food, it goes down our swallowing pipe or the esophagus, and it ultimately winds up in our stomach. To keep it in our stomach and not to go back up, there is, in fact, a physiologic muscle, a narrowing, that keeps the food from going back up again. That valve is called the lower esophageal sphincter, and it's a fancy term for just an area of your body that kind of keeps the contents of the stomach from going back where they don't belong, which is back into your swallowing pipe, and of course, if it's really bad, back into your mouth, which we don't want either.
Thanks, Dmitry, for clarifying that. And again, to the group watching, if you have any questions, please put them on the chat, and either Mary Beth or I will bring them to our panelists as well. Thank you, Dmitry. Dr. Anwar, I have a question for you as an interventional cardiologist, and this comes up a lot. You know, who should be screened for cardiac disease, and what modalities are there to be screened, to utilize for a screening purpose?
Excellent question. So, I think everyone should be screened for coronary disease. Coronary disease is still the leading cause of death in the United States and the world. Right now, there's a lot of advantage of screening, of course, and there's a lot of modalities. I always recommend to my patients, anyone greater than the age of 40 should be screened. And maybe in my practice, I'm a little bit aggressive by recommending age of 40, but because I like to know if patients have coronary disease, that I could do intervene medically and prevent it from developing a heart attack in the future, or even developing significant stenosis that requires stenting in the future. So because of the prevalence of coronary disease, I recommend it to everyone age 40 and up.
Okay, so we have our first chat question. What are the screenings? Which ones would you particularly recommend? We can talk about stress testing, echocardiograms, EKGs, calcium scores. If you can elaborate on some of those, I think.
Absolutely. So in the recent past couple of years, calcium score have basically emerged in our tools for screening. So when we screen patients as cardiologists, we look at many things. We look at the risk factors and we decide what type of screening. But the most easiest test to screen is calcium score. And this could be, a lot of my referrals are from primary care physicians who screen their patients and it turned out to be high calcium score. And what does that entirely mean is that, or how it is done first is basically you go under CAT scan, it's low radiation, not a full CAT scan with all the radiation. And there's no IVs, there's no contrast. And literally the patient would lie under a CAT scan for 10-15 seconds. And then the computer or the machine would scan the heart from outside, looking for evidence of blockage. And it basically detects calcium. And when calcium developed in the heart arteries, that basically tell us that there's coronary artery disease going on. And not only tells us if there's any coronary disease, but also tell us the degree of coronary disease. So they either tell us if there's no coronary disease, if there's minimal, mild, moderate, or severe. And that really helps me a lot as a cardiologist to guide the next step, whether it's being aggressive in treatment or whether, work with the patient as far as lifestyle modification, or whether we, even if his symptoms are very convincing, to take it further and do stress test. Now, the next type of screening is stress test. And there are two types. One is by the patient doing the stress himself by doing an exercise stress test, whether it's by bicycle or by the treadmill. And the second one is chemical. And both of them are about the same. Just the chemical one, we also add nuclear imaging to it to give us a full 3D picture of the heart and underlying the area that's not getting enough blood.
So the calcium score is a CAT scan you don't need an intravenous line, meaning you don't get stuck for it. You lie under the camera for about 15 seconds and you can do that. A stress test is on the treadmill.
Stress test, there are two kinds.
Right.
There's one chemical and one the treadmill. Right.
And they give us information that allow you to determine if somebody has heart disease, correct?
Correct, yes. There's also one more modality. It's coronary CT, which is similar to calcium score in a way that they use a CAT scan. However, this one, it involves contrast injection. And basically, this is as if you're getting a heart catheterization without the invasive part of it. And the contrast basically outline the arteries and see if there's any blockage inside the heart.
Terrific. Okay, so we have another chat discussion, which says it's the first time I've heard of a calcium score. So that's great that we're actually bringing this out to this population, let them know what's available for them.
Oh yeah, it's I think in my patients now, I found that there's a very good correlation between calcium score and stress test. And it's kind of like my first step to it when I see a patient. I tell them I want to know about your heart, and the way to do it, I want to put you in the calcium score because that kind of tells me. And that's why I recommend it to anyone age 40 and up. And I always tell my patients, always good to know early whether you have the disease in your artery or not.
And let's clarify this for participants, that a calcium score doesn't always equate with significant heart disease. It can tell you if you have something that's mild. It can even tell you if you have 0 score. And sometimes instead of being aggressive with doing stress tests, you will just treat with medications or recommend lifestyle changes, correct?
Correct, yes.
Excellent. Correct. Okay. Dr. Anwar, thank you.
You're welcome.
Dr. Gonzalez, I have a question for you as a family practitioner. We're in a pandemic and it's touched everybody. And one of the things we hear in the lay news, and one of the things everybody talks about is vaccinations. So would you take a few minutes and discuss with this group about the vaccinations in general and some of the myths about them so we can clarify and give them some good scientific information.
Sure. So I'm sure everyone is aware that the vaccines that we have now, there's multiple types. We have Pfizer, Moderna, Johnson & Johnson. There's a few other ones in the pipeline. I've heard of the COVID pill, which is currently in process. But one of the biggest myths or people are concerned about is the safety of these vaccines. Sometimes they'll say, you know, the vaccines were developed too fast, or if I'm vaccinated, do I need a mask? As far as the safety and efficacy, obviously it's been shown that these vaccines are very effective. They're effective more than most of the vaccines that we've had in the past, including the flu. As far as safety goes, we've demonstrated huge amounts of safety. People are concerned that the mRNA was a new type of vaccine. What I want to make known is the technology used to develop the mRNA vaccine is not new. It's actually been extensively researched and studied for cancer research. We kind of just got lucky when we found out that it was effective towards COVID. It's been known to be effective towards past illnesses like Zika, rabies, cytomegalovirus, or CMV, or any of those kinds of. So they're not new, and that's the biggest kind of myth we want to trump out now. The other vaccine platforms uses basically, other than the mRNA, they use a virus to replicate. Now, those clinical trials for the COVID-19 vaccines were done with the same safety mechanisms, the same rigors as all vaccine trials. There were no cuts, there were no corners cut. The results have been reviewed. They've been approved by multiple independent advisory panels, which is key, because I know when we get into conspiracy theorists, you know, there's these people who have evaluated these vaccines. They're independent. There is no financial gain on their end. The ability for the developers to become more efficient was due to the increased collaboration of basically everybody, the whole world. It was a combination of different countries where everyone collaborated to find newer technologies, the best way to fund these vaccines and things like that. Another myth as far as safety goes is, once I get it, do I have to, you know, still wear a mask? That's another huge myth. So we know the vaccines protect you from getting seriously ill from COVID. In July of this year, the CDC recommended. They changed their, and as everyone knows, the CDC always changes, which is why it's always good to stay up to date. Ask your doctor. You can even look up the CDC yourself. That information there is described, and they don't use a lot of technical terms. They're very easy to read. So if anyone has any questions, always refer to the CDC. But they had recommended vaccines for vaccinated people in certain areas of the U.S. And this was after everyone said once you got vaccinated, you didn't have to wear them. We were not anticipating the Delta variant, which became the highest highly contagious variant that was out at the time. The replication, meaning the ability for Delta to infect other people, was higher than the original strain. So because of Delta, this meant that vaccinated people may still be able to transmit the Delta variant at a similar rate as unvaccinated people. So the whole rumor about I don't need to wear a mask, you may want to wear a mask and distance yourself indoors, especially in big crowds, and be cautious, because this may help protect people who can't get vaccinated. At this point, we're still working on children. I know children were approved last week, 5 and up. But there's all people, despite meeting criteria, they can't get the vaccine. And it's a very small population of people. So the myth about I don't have to wear a mask after I'm vaccinated, we still make that same very much recommendation because of the different variants that are out.
Excellent. Melissa, we have a question in the chat room. I'll just read the question to you. It says, I've received the Pfizer vaccine for the first round of vaccination earlier this year. My recent antibody test resulted in a score of 995, which I'm told is very high. With regards to a booster vaccination now being recommended, is there an advantage to opting for the Moderna vaccine, which I'm hearing results in a longer period of protection, or should I take Pfizer again?
So yes, there has been rumors about which you know, in the beginning, everyone was all about Pfizer. You know, it's 98% effective versus the Moderna, which I believe was around 93 or 94. And then now they're finding out long-term wise that you get a better antibody response with Moderna. I kind of, other than the fact that now they've officially approved mixing of if you require a booster, you don't have to go with the Pfizer. You can mix boosters. But as far as which one you should choose depending on the response, I will stick to my tried and true statement that the best vaccine is the one that's available. So if you've gotten the Moderna, if the Moderna is available for your boost, if only the Moderna is available, get the Moderna. If it's Pfizer, get the Pfizer. Right now, we just want everyone to be protected. To determine what kind of response you have, that it's difficult to say. Everybody's different. But at this point, I rather not anyone pick and choose, or not me, but in general, the CDC, FDA would rather not anyone pick and choose based on what they feel like they might get a bigger response. The answer is just get the one, the boost that is available, whether or not it's Moderna or Pfizer.
Thank you, Melissa. A couple of, for the participants, the CDC website is cdc.gov. And as Dr. Gonzalez says, there are different portals and areas for your interests, and it is written in a very easily readable way. Dr. Olyenikiov, since we just talked about COVID-19, as a surgeon, let me ask you this question, because we know that during the pandemic, a lot of people didn't come into the hospital for fear of getting COVID and for fear of being ill. So can you talk about that and bring us forward to now, where if somebody does require surgery, particularly for having elective surgery, what do you do with them if they've been vaccinated or unvaccinated prior to surgery?
Well, there's no question that many people stayed at home during the height of the COVID last year, and many did not go and see their regular physicians for checkups, for colonoscopies and other screening tests that may have found recently, when people finally are feeling a little bit more safe, found things that need to be surgically managed, whether it's a hernia, a bulge in your belly button or in your groin, or it's a polyp in your colon, or it's a hiatal hernia that needs to get fixed. Getting that taken care of in a timely fashion really is important, because if that condition is worse, if that condition worsens with time. So the longer you wait, the bigger the hernia, the more likely the polyp can turn cancerous, and on and on. And so patients today can come and be really in three different buckets. Bucket one is they're fully vaccinated, and in that case, we tell them, just show us your vaccine card, and then we can schedule you for surgery when it's appropriate, when you and your family feel it's the best time for you to get that taken care of. The next bucket is the, I haven't gotten around to getting vaccinated yet, or I have a medical condition that doesn't allow me to get vaccinated right now. In that situation, all our patients are asked to get a COVID test, and that COVID test needs to occur within 5 to 6 days of surgery. And then the patient's asked, once the COVID test comes back negative, the patient is then asked to basically avoid other people and self-quarantine, so that at the time of surgery, they do not have a new onset or a new infection of COVID. And the reason we're concerned with COVID and surgery is we know that if a patient undergoes elective surgery and they then come down or have COVID at the time of the surgery, the chance of having a complication leading to death is as high as 25% for an operation that usually may have almost no death risk whatsoever. And that is a huge, huge risk that we don't want our patients to take. So as a result, if you fall in the third bucket, which is I just got told I have COVID, I just tested positive for COVID, or all of my loved ones recently had COVID and I think I had COVID, What we usually say to our patients is from the time of your COVID test that's positive to the time you're okay for surgery, if you didn't have to be hospitalized, if you were able to just kind of live at home and kind of get through it, it's at least 10 days. If, on the other hand, you had an episode of COVID that required a hospitalization, especially if you had to go to the intensive care unit, then we recommend waiting as long as 3 months before any surgery is undertaken. So those are basically the three buckets that we see commonly in surgery.
Thanks, Dmitry. So if somebody has symptoms that require surgery or a condition that requires surgery, your recommendation is at this point, with the protocols in place at the hospital, particularly at Monmouth Medical Center, you would recommend do not delay, but follow the protocols that you've outlined.
Absolutely. We know that those who delayed in 2020 and then ultimately went on to have surgery this year had worse outcomes for the same condition had they had that same operation and didn't delay. So we know that for a fact now. And so if you have a condition that requires surgery, do not delay. Come and get it taken care of.
Excellent. Thank you. Thank you, Dmitry. I appreciate that. Dr. Anwar, we'll pivot a little bit away from COVID just for a moment or two. I used the term interventional cardiologist before with you. And I want to make sure everybody understands what that is and what a cardiac catheterization is, what you can do with that. And would you take a few minutes to explain those terminologies and what it means to this population, please?
Of course. So intervention cardiologist, to become an intervention cardiologist, you go to a cardiology fellowship first, and then additional years of training in interventions. And basically, intervention cardiologist is a physician who can intervene on coronary disease, can put stents. We can put stents in the heart and the legs. We can also do some structural work like TAVR, which is replacing the aortic valve through the groin. We can also do other stuff such as the Watchman device, which is putting a device in the heart to prevent blood clots if you have atrial fibrillation. So intervention cardiology, basically the extra year of training is to learn how to deal, how to intervene on blockage in a more of a mechanical, hands-on way. And now, as far as the cardiac catheterization, again, in the past couple of years, there has been a push to do a heart catheterization from the wrist instead of from the groin. But heart catheterization is basically when we take the patient to the cath lab and put him on a table and invasively go inside the heart and inject contrast under a camera, an X-ray camera that records continuously, looking for coronary artery disease. And a lot of people, they get scared when they hear that because, again, they think of it surgery. I always tell them it's a procedure, and it's a minimum, in my opinion, it's a minimal procedure. The chance of success is 99.5%. Complication rate is less than 1%. And most of it, we can take care of it in the cath lab. And patient, anyone really could be a candidate for cardiac catheterization. There are very few exclusions. Of course, if you're infected, then that might put a hold into the procedure. But other than that, really, or if your electrolytes are very abnormal, such as your kidney, if you're in kidney failure, we cannot take it to the cath lab without a clearance from a nephrologist. And the procedure is done under moderate sedation. The patients are not sleeping during the procedure because a lot of patients, they feel they don't want anesthesia because they're afraid of the side effects of the anesthesia. This is moderate sedation. And in fact, in Europe and some countries, sometimes they don't even give anything. They just give the patient, pain medicine by mouth before they take him to the cath lab, and that's it. A lot of anxiety about the procedure, but when patients go through it and they come out, they feel that it's really nothing. And the pain that's included as I always tell the patient, the pain of getting an IV in, this is really all what you're going to experience, nothing more than that. Doing the procedure from the wrist had really lessened the chance of bleeding. Generally the bleeding is less than 1%, even from the groin. But with the wrist being the main access site now, we're talking about like 0.05% of it having any problems, or I'm sorry, 0.5% of having any major problems. And the benefit of the wrist is that, you know, you go from the wrist, you don't have to lie flat for 6 hours. You can just stand up, you go to the bathroom, and you know, in a couple of hours you're home. Most of this procedure is same-day procedure. You come in the morning and you leave after by 2 hours, or if we have to intervene and put a stent, 6 hours and you're home. So that's basically what do we do as intervention cardiologists. And the main thing is that we put stents. Stents are metal, and they're basically delivered over a balloon, and then we inflate the balloon to inflate the stent, and that stays in the artery. The common questions that I get sometimes with stents, are they permanent? And the answer is yes. We cannot, once we deploy him, we cannot take him back. And it's basically pushing the plaque to the side, the side of the vessel, to maintain the blood flow inside the artery. And there are medicated stents, and the research have shown that medicated stents, they last longer. So that's why we use them.
Thank you, David. A follow-up question. You use some technical terms. I want to make sure that the group understands them. You use the term TAVR. Right.
So TAVR is basically, it's a modality that we use. We change the valve from the groin.
So let me just clarify. We're talking about somebody who has a valve that's not functioning or opening up the way it should, and you want to get it to work again. And instead of doing open heart surgery, you can do a procedure called TAVR to open up that valve for the patient. Correct?
Correct. Yeah, it's particularly aortic stenosis, the main valve that connects the rest of the body to the heart. That's the most common valve that we see problem with it. And again, with the TAVR basically been there for maybe about 5 or 7 years, and yeah, it used to be a big deal, especially if you're 80 or 90 years old, and you know everyone is afraid to operate on you because the chances of of not making it out is pretty high. Now this TAVR came along and people are doing it, and it's been a lot of success. So yes. We go from the groin, and you're not under anesthesia, and it's and next day you're out. Basically, you're home.
Terrific. Thank you for clarifying that for me.
No problem. Thank you.
Melissa, I have a question for you. As a family practitioner, a primary care physician, and we're at the SCAN network for this presentation. So, what preventative care would you recommend for your senior population?
So preventative services are for everybody, first off. This is especially important in older adults because the risk for health problems increases as you age. So by preventing problems or identifying them early, you're likely to live longer, healthier, and more satisfying life. So many physicians follow certain service guidelines from the U.S. Preventative Services Task Force. This is basically an expert panel who reviews research, advises doctors about which preventative services, depending on your age, medical history, and family history. Preventative services include screenings, vaccine, and health advice. One of the main ones that are huge for the older population is the Medicare annual wellness exam, the famous Medicare wellness exam. This is a one-year visit every year. The doctor measures your height, weight, your body mass index. Your doctor will talk to you about all the medications you're taking. Now, medications including prescription and non-prescription. A lot of the times when people think of a medicine list, they think of the only ones with the label on it in the orange bottles. That includes ginkgo biloba, saw palmetto, which is very common as you get older, for the elderberry recently because of COVID. Always let your doctor know all and every medication that you take orally, whether or not it's prescription. They also will talk to you about your eating habits. They'll talk to you about your activity level. The Medicare Wellness visit is a good way to assess and check your overall health. A part of that visit is vaccines. The influenza vaccine, it's a yearly vaccine. It helps prevent influenza. Older adults should definitely get this vaccine every year. Between 70 to 85% of deaths from influenza are in individuals 65 years of age or older. Same thing with the pneumococcal vaccines. There's two kinds. There's a, fancy words, there's a polysaccharide vaccine and there's a conjugate vaccine. Basically, they both are important to help prevent pneumonia. For people who get pneumonia, that helps prevent any life-threatening complications that occur from pneumonia. And again, this is especially important for older adults since they are more likely to get pneumonia and those complications. As regarding to the screening, you have breast cancer screening. More than 40% of all new breast cancer cases are in women 65 years of older. Women between the ages of 50 and 74 should have a mammogram annually or sooner if indicated by previous mammos. And depending on your current risk factors, family health, your doctor may actually recommend you get them more often. On top of the screening, another screening is a colorectal cancer screening, which Dr. Olyenikiov had touched on before. 60% of new colorectal cancer cases are in adults 70 years in age and older. I'm a family medicine physician, so I report to the AFP, the American Academy of Family Physicians, and they recommend screening for colorectal cancer with different modalities. You don't have to get a colonoscopy. There's flexible sigmoidoscopy. There's the immunochemical tests, which are, they check for DNA, the Cologuard. I'm sure there's tons of commercials on the Cologuard now. So there is definitely different options. If the colonoscopy is not the way that most individuals like to go, there are options. Dr. Anwar had touched on cardiovascular risk evaluation, cholesterol screening, calcium channel score screening. High cholesterol is a huge risk factor for heart disease. Men, even over the age of 35 and older, and women 45 and older should always have their cholesterol levels checked on a regular basis. Those who are older and who have risk factors for heart disease should be tested. They can go to their cardiologist for all the above testing that Dr. Anwar had just mentioned before. On top of cholesterol screening, there's diabetes screening. Diabetes is very common in older adults. It affects 1 out of every 4 adults 65 years of age and older. So if you're overweight or obese, your doctor may test you for diabetes, even if you don't have symptoms, which is why it's screening. Screening is basically when you check for disease if you don't have any symptoms. There's high blood pressure screening. The possibility of developing high blood pressure increases as you get older. Your doctor will usually check this every time you're in the office. Usually if you're only there, if you have no active medical problems at your annual exam. And for women, there's osteoporosis screening. Any woman over 65 years of age and older should be tested for osteoporosis. This basically, it's an x-ray that checks your bone mass, how thin your bone is, and that value will basically that works with your risk of breaking anything or risk of fractures. And once you fracture, that's a whole nother ball game. So this is a screening to prevent that. Then based on your screening, there's medications that help you rebuild bone if it's that thin, and there's medications that help prevent further progression of your osteoporosis. So there's a lot of things to consider. Skipping any of those services is dangerous because some diseases and conditions may not be found in time for effective treatment. So that is a lot of the preventative services that you can definitely ask your doctor about.
Thank you. I have a follow-up question for you. You mentioned the flu shot. So if somebody's getting a booster or getting their initial COVID vaccine, can they have a flu shot at the same time? Is it recommended or should it be spaced out?
So right at this point in time, they are recommending that if you can get it, get it. So yes, you can get them at the same time. They are giving them out at the same time in a lot of CVS locations. They're doing them both. Always be advised that if you're 65 or older, you get the high dose influenza vaccine as opposed to what everyone else gets. But yes, they are. You can get them together. Yes.
So you can get them at the same time. You don't have to wait. Correct?
Right. Correct.
Excellent. Okay. We have a question from the chat room. I'll just read the question. What about the shingles vaccine? Should all adults consider this vaccine?
So yes, that is part. The shingles vaccine is actually given at a younger age than the pneumonia and the the flu is given to everyone, but it is recommended at an earlier age for that. The shingles is basically a reactivation of the varicella. Unfortunately, in adults, getting shingles or chickenpox for the second time can actually cause more complications. So that is recommended definitely in the older population to get your shingles vaccine. Getting shingles itself is not only painful, it can lead to complications. So if you haven't gotten it, that is a recommendation. Again, shingles is one of the vaccines that you can get at the walk-in clinics, CVS, Walgreens, even if your doctor does not provide them. And the reason why I say that is because my offices, we don't do the shingles vaccine, but I recommend all my patients who qualify to get them.
Thank you, Melissa. I appreciate that. Dmitry, question for you. So you had mentioned in one of your answers about a bulge, a hernia. So as a surgeon, can you talk about hernias in general? When is surgery indicated and how we do them?
Absolutely. A hernia is a very, very common problem that many people have and don't know about it until it's an emergency. And typically those, as I'm sure everybody understands, usually happens on an evening or a night, and not definitely when one wants to go to the emergency room, that's for sure. So one thing that we've started to do is to really reach out to the primary care physicians and ultimately to our neighbors and friends and say, listen, you need to be screened just like you're screened for colon problems or for heart problems. You need to be screened for hernias. A hernia screen basically is a quick physical exam that your doctor can perform, or you can perform yourself, where you're basically trying to figure out, is there an opening in your belly button or in your groin or somewhere on your tummy where you've had previous surgery that is basically broken apart. I tell my patients the best way to think of a hernia is, if you could see my jacket right here, where there's a hole in the button, something is going through that little hole. What's going through that little hole are the contents of your abdomen. And of course, if they get twisted or stuck in there, that's an emergency. That's called strangulated hernia. So what we say to people is, if you feel a lump or a bulge, especially when you're cough or when you're bearing down to lift something up, that should be a concern. That bulge, whether it's in your groin, in your tummy, or anywhere on your abdomen, should be seen by your physician. And then the treatment for that today is a minimally invasive outpatient procedure. You come in, we basically patch it up, and then we send you home. And most of my patients always tell me, oh, I was told that this, if I have to have this operation, I'd have to stay in the hospital. I couldn't lift anything up for months and months. And that's how we used to think about it in the old days. Today, the operation is done at our institution, for instance, virtually 100% of the time through minimal access, meaning small incisions. Almost 90% of the time as an outpatient, come in, get it done, go home same day. And if it's done in that manner, most patients can get back to full activity in just 2 weeks. So just 2 weeks of taking it easy, certainly not avoiding going to the store or going for a walk, just not doing anything that's really, really strenuous. So it's a great time for all of us to really look after our health and get that hernia screening done.
Dmitry, I'm going to follow up on something you mentioned. You used the word strangulation. When is a hernia an emergency?
That's a great question. Unfortunately, when you have a bulge, and what's bulging are the contents of your abdomen, if that gets stuck in there and doesn't go back in by itself, you will develop poor blood supply to those organs. It could be a piece of colon, it could be a piece of small intestine, it could be your stomach, and anything anything that you can find in your tummy, including your appendix, can get stuck in a hernia, believe it or not. It's called the Litrace hernia. So you can look that up next time you're doing trivia pursuit. And so if that occurs, you get pain, And it's an emergency. You have to go to the emergency room immediately, or the bowel or the contents may burst, causing to peritonitis, sepsis, or some other terrible things that you don't want.
So if somebody has that kind of those symptoms, they should really either call their doctor or go to the emergency room, make sure it's not an emergency.
Absolutely. If you have a bulge that's hard, that doesn't go back in, that becomes painful, that's an emergency.
Thank you, Dmitry. David, I'm going to switch to you next. And we didn't touch on COVID in cardiology yet. So I have a two-part question for you. One is, how is the COVID pandemic affecting what you see are people delaying their treatment for heart attacks and heart disease? And the second question is, you did mention in your last answer atrial fibrillation. If you could explain that as well.
Of course. So, I see COVID affecting patients with heart disease in outpatient setting and in the hospital. And honestly, the hospital is more dangerous because a lot of presentation of heart attacks are delayed because patients don't want to come to the ER. So patient will be having chest pain and we ask him, when did it start? Like earlier in the day. I'm like, but this is nighttime now. And that's serious. And, a lot of people with chest pain end up having heart attack that they're just sitting at home. And
well, David, let me interrupt you here. Does time matter?
Of course. When you have a heart attack, basically you're cutting the blood supply to the heart, to that area of the heart. So of course, the sooner you get to the hospital and we unclog the heart, the better the recovery and the better chances that the heart muscle would recover 100%. They always teach us that time is muscle in cardiology. So the longer the time, the more muscle you're losing. The shorter the time, the chances the muscle would recover completely. So yeah, I mean, the scare that, I had a patient tell me, well, I didn't want to come to the hospital. I'd rather die at home with a heart attack than die from COVID. And, that might be back in March, but right now when everyone is vaccinated, or a lot of people are vaccinated and we have so many different treatments for COVID, that shouldn't be the mindset. It should never be the mindset, to be honest with you. Now, in the outpatient setting, I see it with the follow-ups. How come you didn't come and see me in 2 years? It's like, well, I was home. I was afraid from COVID. I didn't want to go anywhere. And of course, being sedentary did not help anything either. Most of those patients, their cholesterol panel is very elevated, and all what they do at home is just sit down and eat more and lack of activity, which created multiple problems. And mainly, if you don't take care of like hypertension or hyperlipidemia, they all start to develop in the coronaries, and sometimes when they develop, it's irreversible. So yeah, we do see as far as delay of care from both ends, from the outpatient setting as well as the hospital setting. And then the second question you asked me is about atrial fibrillation. Atrial fibrillation is a heart rhythm disorder where instead of the heart contracting in the normal fashion, the upper chambers of the heart fibrillate. And I always tell my patients, instead of using the word fibrillation, use the word vibration. So instead of having the normal contraction, they just vibrate. The issue is that when the upper chamber vibrates, they do not empty the whole entire blood volume into the lower chambers where it gets directed or rerouted to the rest of the body. And those 10% or 20% of the blood that do not go down to the ventricles, the bottom chambers of the heart, if they just sit there vibrating, they stagnate. And when they stagnate, they form a blood clot. And that's the dangers of atrial fibrillation. You can develop blood clot that could go to the brain and cause a stroke.
Excellent. Thank you for the clarification. I appreciate that.
Thank you, Dr. Granet.
Melissa, I'm going to pivot to you now. We had talked in the last question about some preventative care in general and procedures in specifics. In your practice, how do you tell your patients, like, what's the best pathway to stay healthy? What's the path? How do you teach them to stay healthy?
So we, on top of the screening questions, on top of being, having your blood pressure and your weight under control, I believe a healthy brain is just as important as a healthy body. So on the path of, to overall improved health, nourish your brain. Now, what I mean by that, so cognitive health is basically how well your body performs mental processes, how you remember things, how you use language. So a healthy brain is just as important as a healthy body. Many of the things that you do to keep your body healthy can also keep your brain healthy. Cognitive decline is basically when your brain doesn't work as it used to. Like, for example, if someone is experiencing cognitive decline, they may have trouble remembering or losing language, remembering things. Now, this isn't, remembering where you put your keys. This is remembering things that you normally would, your route home, how to get home, remembering how to take care of yourself. And, some cognitive decline is a normal part of growing older. But then there's a cognitive decline that happens quickly, like from head injury or stroke or other kinds of diseases. So one of that I tell my patients, brain health. That includes, there's any one specific diet for brain health, but eating healthy is important for your overall health. But ways to nourish your brain, manage your weight, honestly. Studies show that obesity, diabetes, high blood pressure, all that stuff can increase your risk of dementia. Lose weight and keep it off. No yo-yoing, no short-term diets, no fad diets. Adopt a healthy way of thinking about and eating food. Eating fruits, vegetables, and whole grains. I know this is said, everyone knows to eat everything, but that to actively participate, to actively have those as part of your daily diet is huge. A diet that includes lots of fruits and vegetables and whole grains can reduce your risk of chronic diseases, not just, heart disease, but diabetes and even cancer. These are the same foods that protect brain function. We're talking about leafy greens, dark skin vegetables, cruciferous vegetables, which is, cauliflower, broccoli, turnips. Those are known to be protective. Vegetables, beets, broccolis, eggplant, all those, like I said, the green leafy ones are very good choices. Avoid unhealthy fats. Trans fats is a big no-no. Man-made fats, even though they're the most delicious. Any trans fats are usually used in processed foods and store-bought baked goods. So I tell my patients, try to avoid that. I mean, obviously with the holidays coming up, it's a little hard, but read the food labels carefully. Check for trans fats. They usually appear as hydrogenated vegetable oil, partially hydrogenated vegetable oil. Another example of high-fat foods are red meat. Most people don't consume a lot of red meat, but that also can contribute to high blood pressure. When you do eat red meat, reduce portion size. Choose poultry and fish more often. Avoid unhealthy fats. Use olive oil, use canola oil when you are sauteing foods. Bake, broil, roast instead of frying. Get your omega-3 acids in. That's the most common source of omega-3 fatty acids is, sardines, tuna, salmon. You try to eat that once or twice a week. Talk to your doctor about the benefits and risks of taking vitamins and supplements. I know it's very easy to get on to be taking, vitamin C, zinc, everything individually. Doctors may suggest a dietary supplement based on your diet and on your overall health. Other things other than those tips, what else you can do to maintain brain health? Stay physically, socially, and mentally active. Right now, there was a huge, as the other doctors on the platform had talked about, people didn't want to leave their house. That social interaction had a huge effect on not a single population of people, but everybody in general. Cardiovascular walking went down, biking, hiking, all that went down. So I tell people, get back on that horse of taking care of and of getting your heart rate up, but choosing good options, ones that won't hurt you and ones that you enjoy. Any activity that you do with other people helps stimulate your brain. Social activity. Right now, everyone knows what Zoom is, go-to meetings. We have FaceTime capabilities on iPhones. Walking around the block with the neighbor, if they're not vaccinated, maintaining social distance and masking. But, you know, things like that, getting involved into a sport, a hobby, or topic. Keeping your brain cells strong and active is important to being mentally active, and that's important to overall health. I always tell my patients, challenge yourself to something new, read, stay informed, enroll in a class, or do games or puzzles at home. You know, it is normal for your memory to lag as you get older. You know, like I said, forgetting where your keys are is not a sign of Alzheimer's, but being unable to retrace your steps could be a key sign of that. You know, losing track of dates or seasons, or difficulty completing familiar tasks is known for that. But taking care of your body and brain is the best ways to prolong cognitive and every overall health.
Thank you, Melissa. Actually, we have a chat question which was directed to me. So I'll read the question. It says, Dr. Granet, will we be able to obtain this recording? And Mary Beth did answer. This discussion is being recorded and linked to view will be sent to all participants and also available at scanj.org, and look for the YouTube channel link. So I just noticed the time. We're basically out of time for our hour. I want to thank all of you for participating. Are there any other questions before we break off for any of our participants? If not, I want to thank Dr. Gonzalez, Dr. Anwar, and Dr. Olyenikiov.
Thank you.
And Mary Beth, I'll turn the last remaining minute or two over to you.
Thank you. Well, I want to thank everyone for a great discussion today. Thank you for addressing brain health, Dr. Gonzalez. That is our mission here at SCAN. We talk about brain health and how important that is, as well as your physical health. So staying engaged, you know, we kept our members engaged with the online platform.
Excellent.
It's just as good as in person if you know you don't feel comfortable doing in person. So thank you for addressing that as well. So thank you so much, Dr. Granet, for moderating today, and for our other physicians for being here today. I wish you all a good afternoon, and your contact information will be shared with all the participants today when they receive their thank you note from the webinar attendance. So thank you again, and have a great afternoon.